Hello and welcome everybody to our next session at the Virtual Patient Safety Congress. We have a stellar panel. This is going to be really good and really interesting, hopefully. Obviously, we're looking at the issue around assessing and managing patients in the community with suspected COVID. There are some really interesting developments going on in this space. And as you can see there, we have an excellent panel of speakers who it will take me as long to introduce them as it will just to get on with it. So I'm going to pause there and ask all our speakers to join us and activate their cameras. And John Cordwell is going to go first. He's a COVID-19 patient and also a GP in the Northwest Clinical Lead. So John, over to you.
Thank you, Sean. My particular experience with COVID started on the 21st of March of this year, when I was working for the local out-of-hours service and dealing with patients from home in our new virtual environment. And I developed quite a high fever and a headache and cough, which became disabling over quite a short period of time. So I rang our shift manager and had to finish my session an hour early. Over the next few days, I had quite a high fever and cough, and because I've been involved in deterioration work and worked with Matt in Ardekim before, I was monitoring my own news too at home. So over the first week, my news too was running at 3 to 4 with slightly low oxygen saturations and a fever and a bit of a tachycardia. So as the week progressed, I felt okay. I was managing to do all the things I wanted to do, but I had been self-isolating from the first night, and we'd disappeared off to the spare room and stayed there. And my family were coming along to check on me from time to time. It was a little over a week after the start of my symptoms that my oxygen saturations began to decline. And on the 1st of November, my daughter, who happens to be a staff nurse, came to the door of my room, and she stood there and asked me how I felt. And at that stage, I responded by saying, "If I don't move, I don't cough." And that was the experience of the cough that was really most noticeable. I did feel a little breathless, and I had a respiratory rate of 28, which she counted from the door. Threw me the SATS monitor, and I checked my oxygen saturations, and it was 90. So I went into the Royal Liverpool Hospital that morning, and on arrival at the A&E department, I had a news too of 8 with elevated respiratory rate, low oxygen saturation, a tachycardia, and a fever. So I was admitted to the Royal Liverpool Hospital, and I was looked after very well indeed. I was on oxygen for 5 days by nasal cannula, and I was treated to IV antibiotics and the low molecular weight heparin, and I was proned and treated according to the standard protocol. Fortunately, I recovered very well, and on day 5, I was able to maintain my oxygen saturation above 95% without having oxygen. So I was allowed home on that day, and I continued to recover over the next few weeks, and was back at work about 2 weeks after being released from the hospital. During the admission, I'd had a very typical appearance of COVID. When I was admitted through the A&E department, they did a 40-step walk test with me, which showed that I desaturated from a peripheral oxygen saturation of 90 to 83 on a 40-step walk. When I had my blood taken for arterial gases, my arterial blood gas was 8.9 kilopascals. So I was significantly hypoxic, without a doubt. As a patient, it was quite difficult as a doctor being a patient. I probably presented later than I should have done, and only really at the instigation of my daughter. And it was quite difficult being a doctor in that environment, because I felt that I should have been getting better faster, and I found it difficult to actually take on the patient role. But it's been valuable in terms of informing my way I deal with patients who have COVID when I speak to them now. And I feel that I have certainly developed some insight into what happens to patients with COVID. And I'm interested in seeing how people's symptom patterns develop over time and how the recovery goes, because I was fortunate to have a quick recovery, but I know a lot of patients have not had such a quick recovery as that. And it may well be that some patients have symptoms for many, many months. So that was my experience. I've been back at work since then, and I've now taken on leadership of the Northwest Coast Innovation Agency clinical lead role for the COVID virtual wards, which no doubt we'll be hearing about later. So I'd like to pass this back now to Sean and see what the rest of you all have to say.
Thank you, John. And interesting, doctors must make the worst patients. I'm sure they do. But Matt, do take us on from there. We've got Matt Inardikim, who's an acute physician at the Royal Hampshire County Hospital and national clinical lead for deterioration at NHS England, and is going to take us on from there. Go ahead, Matt.
Thank you. And thank you very much, John. Do you mind popping up the first slide? So we're really privileged to have a leader like John with such massive experience of all things COVID coming into the fore. Can that be full screen at all for me as well, or is that impossible? So I'm an acute physician, as Sean says, former GP and carer to patients. And all throughout First Peak, like many of you, I kind of encountered this condition of silent hypoxia right from the start, something which I think John alludes to in what he says. Various political commentators also spotted it, the onset of extreme breathlessness or lack of extreme breathlessness, accompanied by very low oxygen levels, with the paucity of really severe deterioration type symptoms, the sort of condition that can creep up on you, essentially. And what it led to us really realizing was that without an oximeter, you really couldn't tell whether someone had silent hypoxia or not, because it was done obviously with the absence of symptoms. And what it led to the realization was that actually this was about what we do in the community. This is what we do in our own homes, potentially, in terms of monitoring and looking out for deterioration signs and signals.
Sorry, Matt, sorry to interrupt. The audience can't see the slides?
Yeah, I can't see them either.
I can see them. Let's see. So if
sorry for the interruption.
I'm guessing I'm talking about the right slide, but
so there should be a video screen that you, if everybody looks for the video screen of the slide, and then picks pin video, it should come up. But I'm being told that we are working on it in the background. So
I think so. If you double click one of the screens, I think it comes up, doesn't it?
It does, yes.
So
you can also pin it as your video as well.
Okay.
But if people can see that screen, then double click it. But we are working on it.
I'll just carry on talking.
Thanks, Matt.
So I'm assuming you're on slide 1 still. So what this is about really is thinking about the community, is about empowering patients with the potential for pulse oximeters, particularly in those vulnerable at risk patients, to try and combat what we saw during First Peak, which was a very high case fatality rate. And interestingly, when you looked internationally at different countries around the world and how they performed during First Peak, what we realized quite early on was that the higher your level of oxygen saturation is, your tolerance level, the worse you did. So if your oxygen saturation level as a country was around 91, 92% for dictating when you admitted a patient and gave them oxygen, you actually did worse than a country that had a threshold of 95, 96%. And that was true of an interesting study done by Gibraltar that looked at 29 developed countries around the world. What we're seeing with second peak now is a mirror of what we saw with Spanish flu in some ways, with a ton more cases now. And the question is how we respond as a system. This is not about just primary care. It's not about hospitals. It's not just about commissioning or NHS England or any arm's length body you could mention. This is about our whole system's response, the whole of our country's response to what is a critical threat. Next slide, please. So what we realized, I suppose, from our early research, and this is from doing analysis between ambulance services and the outcomes in a hospital, was that actually oxygen saturations have a massive impact in terms of survival. And if you look at the whole population that was transferred to hospital, and this does include palliative patients, we found that if your SATs were 92% or less, you were sitting at nearly 30%, 30-day mortality when you came into hospital with a diagnosis of suspected COVID. And that this was a reading that you could actually pick up in the community at home at the time of your ambulance assessment. And that if you have a higher oxygen saturation in the 93 to 94% mark, you can essentially halve that 30-day mortality. And you halve it again if you're in there at an even earlier point than that. And that's really influenced where we put our lines in the sand for oxygen saturations from a safety netting perspective, and also what we hope to release as our guidance to all patients. And that's coming in about 5 or 6 days' time. You can see from the curve that actually the difference in survival over a few oxygen saturation percentage points is massive. Next slide, please. And this is a really important thing going forward with the survival rate that varies between 75 and 95%. Can you go to next slide, please? So this paper came out of the weekend, and in it, we essentially validated the use of home oxygen saturations in patients that were eventually conveyed to hospital. And as you can see from that graph in the right-hand top area, the mortality rate rises as one gets lower and lower on the oxygen saturations. The link is in the chat. And what it really proposes is that we need to keep things really simple. So whilst complex scores are really, really good, I suppose, in a retrospectoscope manner, or when you arrive in a hospital setting where you can do all the tests. But what we're really crying out for is an early warning system for patients at home, potentially. And this is potentially where home oxygen saturation readings may have something to offer. And it really spells out that even a very minor deflection of oxygen saturations is associated with a higher mortality rate. In fact, just a minor deflection in a range that we previously considered normal. And we need to really potentially rethink how we strategize, we plan, and we put our pathways in action for patients with suspected COVID. Next slide, please. So the how in this is about aligning our pathways, thinking about that COVID virtual ward strategy and thinking about the safety netting. And this kind of virtual ward or COVID oximetry at home is an interchangeable term to think about how we do that patient self-monitoring in a home environment, supervised by healthcare professionals in a way that we pick up silent hypoxia early and early deterioration. This is about early intervention. We don't want to be seeing patients in their 70s or, sorry, John, in their 80s with COVID. We want us to be seeing them in the 90s. And this is the challenge that faces all of us. It's also about what tech we can support. And we have NHSX that's doing terrific work in this area. We have the evaluation that's being led by Aradazi and Naomi Phillip and the Nuffield and Public Health England that will help guide us towards the right strategy here. And we then need to go for scale and spread at scale really quickly. Next slide, please. The model itself revolves around a similar approach based on whether you're in a hospital, the community setting, or indeed the ambulance sector, where you get your clinical assessment, you get risk assessment, you get a COVID swab potentially, and usually a drive-through type environment. And if you rule out COVID, you don't forget about everything else. And this is really important. Other things can kill you too. God forbid we just focus on one condition in a blinkered fashion. That will not save any lives. And then once you have that label of suspected or confirmed COVID, You then enter a risk assessment. And if you're low risk, you get kind of passive follow-up with safety netting and a diary. And actually, certain age groups and certain demographics of population have a very, very low risk of either emergency admission or death. Doesn't mean they're completely safe, but it's a very, very low risk. If you're in the higher risk category, you enter this virtual ward, which we describe as being this enhanced package of monitoring for patients at future risk of deterioration or admission, provided within a patient's own home. And crucially, it can be managed either in the community or the hospital. And then from that point, you either recover or you deteriorate, and with an admission if you deteriorate. Next slide, please. And this surveillance bit is really important. Alignment of our pathways is also key. And our pathways for primary care, the emergency department, and care homes are all aligned with the same lines in the sand in terms of oxygen saturations when we push the panic button and admit a patient and when we don't. But if you fulfill the criteria for a COVID virtual ward, you enter the pathway if you're high risk and being kept at home so that we don't miss your silent hypoxia. Next slide, please. In terms of what that looks like in primary care, the triage process is really important. A, to decide whether someone is high risk or not, but B, to decide whether someone has an equally dangerous other diagnosis. Primary care will never forget about patients. They are not just one-track groups. This is generalism to the fore. And then once you're into this virtual assessment, we have the oxygen saturations to guide what we do. It's not always possible to do a NEWS2 score because a lot of this is remote assessments. We also need to learn from the first peak about what the serious symptoms of COVID are. And from analysis of patients that died or were admitted, we know that breathlessness, myalgia, severe chills or rigors, or severe fatigue are probably our top 4 main symptoms that are associated with really bad outcomes. We're learning more about acute delirium as well, particularly in the elderly. And these are potentially our signals at the triage stage, potentially at a pathway stage to deciding who potentially needs to be seen more urgently. And we are now raising the standard. So this is about making sure we're aware that actually, if you're in that amber group, the 93 to 94% group, we need to think about a hospital admission and assessment at that point, at a point where we probably wouldn't have done in years gone by. This is about responding to the evidence, doing the assessment, because not all of them will need to come in. Some will bounce back and get to a normal level of oxygen saturations, but some crucially won't. And then you pass on to this personalized care pathway where you consider the patient's needs and what they really want to happen for them. Not everyone wants to come into hospital, and not everyone has that as an appropriate course of action. That is a personalized decision, and that's where good consultation is really important. If you have normal oxygen saturations, as John's example highlights, walk them, do a 40-step walk test or a 1-minute sit to stand, because actually we have good early evidence that that signals a pneumonitis or evidence potentially of early COVID. Next slide, please. So the what here is about the group, the target group. So we know that 65 years or older is probably the right age group, because under that, deaths are really rare. You have to be symptomatic. You also have to have a diagnosis of suspected or likely or confirmed COVID. And then you can also enter this kind of virtual ward if you're under 65, if there's clinical concern or risk. And then if you end up in this high risk category, you get your monitoring with calls at days 2, 5, 7, 10, 12, post-symptom onset. It doesn't need to be done by a qualified GP, a medical consultant, or indeed a senior nurse. Anyone can do this monitoring, and it just demands a little bit of training and supervision. Next slide, please. And we think by doing this, this will actually enable and encourage the safety of this population. Next slide, please. So the resources we've got in Train include this multilingual translation of safety netting advice with how to use an oximeter and what the oxygen saturations mean, a diary to record symptoms and oxygen saturations, videos and YouTubes and animations, translated into different languages, around 200,000 oximeters with more on the way, and apps that have been produced to support this program, as well as interoperable digital systems. Next slide, please. The scale and spread is something we can do in everywhere we work. So in my particular region, we've got a 600,000 population that we've implemented this model in around 2 community hot hubs, one of which is going to speak today with Caroline, which is quite incredible. 100 care homes, an ambulance trust, and an acute trust covering about 600,000 population. So far, we've seen about 2,000 patients with COVID through this. And of the ones we've been able to follow up, which amount to 130, there have been 0 deaths. Quite staggering. We hope to achieve really remarkable reductions in COVID mortality through this model, through earlier presentation. And what's really important going forward is how we create a 24/7 safety system that will enable patients with suspected COVID to get the best care, the right care, all times of day and all days of the week. And this is something we have in train and under discussion at the moment. Watch this space. Next slide, please. So our need is not just to focus on the community, whilst that's really important, but to also think about what happens in a hospital, because the flow through a hospital is one of the key things that links to safety. And what we know from our early first peak data is that we admitted a lot of patients with normal oxygen saturations in first peak, for good reasons probably, but also because we were worried. Now we have the evidence of the tangible link between oxygen saturations and mortality. Perhaps in some cases we can be braver. Perhaps in some cases we can use oxygen saturations to ensure that we have the flow with monitoring that keeps our hospital systems going. Next slide, please. So education is going to be so important here going forward. The competencies of our staff and potentially band 4 type personnel to try and keep these hubs going is really important, both from the referral stage, how we do triage, the onboarding, the monitoring elements, and then eventually recovery and discharge from the COVID oximetry at home model. And colleagues Helen Irving and Sam Sherrington have created a wonderful set of resources that are tuned to this. And Susanna Bernardi at HSJ has produced a wonderful e-learning resource that is available now. The link is in the top, that you can click on and access for free if you're in the NHS, that will train staff in how to manage patients within the COVID virtual ward environment. Next slide, please. So our main methods for supporting our staff in taking this on include a COVID virtual ward forum. This is the link here. This is about complex adaptive work and thinking about the communication between the front line and the center, which is so important going forward, and our implementation toolkit that will guide people. Next slide, please. What's also important is learning and ongoing learning. We run a home oximetry network that has between 75 to 150 members of people setting this up everywhere. You're very welcome to join. We record all of the meetings and we keep all the slides as well to share to others seeking to go down that path. Next slide, please. So where we're left is the next steps, which is we've now defined the clinical model. We've now got a plan for implementation. Through the academic health science networks. And actually now, excitingly, from last night, we got the funding agreed as well. GP letter came out, link is in the slide, which aligns to about £150 million worth of funding towards general practice to cope with second peak of COVID. Number 2 on the list is the COVID oximetry at home strategy, the virtual ward strategy. And that's really exciting news because general practice really needs that funding. But it also should touch on ESTEC as well, we hope, in the hospitals. The evaluation is underway as well. And some of the learning points from our evaluation so far shows that essentially no one size fits all. You require that pan-pathway collaboration that's so important here. You should never wait for perfection. It is the enemy of the good. The monitoring can well be carried out by people with lower experiences. There's a ton of resources out there in a wonderful, vibrant community ready to help. And that we hope through this, we will minimize admissions, length of stay, intensive care, minimize mortality, avoidable deaths, and optimize the patient and staff experience, both from a safety perspective, but also importantly from a quality point of view. And our early data from these pilots is quite astonishing, with an overall mortality rate of 1% from over 1,800 patients. And it's capturing the imagination of our frontline clinicians. This was born from the front line and from patients. This wasn't born from the center. People just got on and did it. They did it in their spare time, in the hours between 5 p.m. and midnight, often enough, setting up these units. And that's led to a massive groundswell of support, the like of which I've never seen in my life. And long may it continue. Thank you very much.
Thank you, Matt. And we'll go straight in there to Calder.
Thank you. Next slide, please. Can't see the slides.
I think there's a, shall we say, a slight delay on the line. There we go.
Thank you. So I'm called Jo Hall, I'm a GP, very much a frontline person, but equally it was about what was going on in the first wave. Next slide, please. And the key ask was, what can GPs do? Because as we were experiencing, it was about the anxiety of ourselves, our patients, and it was about how do you keep staff safe as well as patients safe? And is there something primary care can offer to understand what's going on? The reason I've presented this slide in particular is that if there's any one take-home message is please code the information that you've got within your systems, because you can get a better idea of the number of true cases of COVID as well as suspected COVID. But these codes aren't just applicable to primary care, they're also applicable to secondary care. Through these numbers, as a practice, you can determine what's going on within your own practice as well as at your PCN or borough level. Next slide, please. Equally, as Matt's already alluded to, we've now got an indication of what are guidelines, but equally, you can adapt those to be put into your own clinical systems. Commonly within England, it's primarily EMIS or System 1. Within Northwest London, we've got 2 independent systems and we align the codes together. Next slide, please. But our key ask right at the beginning was actually, we didn't have any COVID-related codes. Back then, as is now, we're still learning a lot about COVID. As I always say, the textbooks are yet to be written, and equally, it is about what additional learning could we do as we went along. Next slide, please. So our process started off by saying, how can we keep our staff safe? How can we keep our patients safe? Hence, we had the hot and cold environment. But equally, what we learned very early on was, what are the parameters and what parameters do we need to look at? And how can we safety net our patients? These slides will be shared, so you can look at these in a bit more detail later. The key purpose of this is on the left-hand side, you can see is trying to make it business as usual. Going towards the right-hand side is how can you empower patients at the same time by giving them relevant patient information leaflets, and safety netting at every single key point was absolutely fundamental to us trying to keep them safe. Next slide, please. So we adopted a process where we had an opportunity to speak at working with NHSX, where we could also use an app. We worked with the Medipad, now known as Huma Group. But the key point here was that there was an app that's available to the patient on their individual phones. From the clinician point of view, we had a dashboard view whereby you can then determine which patients are deteriorating in a very timely manner. The reason I mentioned that is that it's about understanding what are the parameters you set in place and how quickly can you react. The key lesson we were really obviously very nervous about in primary care is, what are the timelines over which a patient can deteriorate? What do we mean by silent hypoxia? Were the guidelines at that moment in time absolutely correct? And hence us being able to share the information we gained, as well as it then being pulled into the national studies and sharing further information as we go along. Next slide, please. Initially, we started off within what we call Hillingdon and EMIS area, as well as Central CCG in Northwest London, 2 key CCGs. So between us, we covered a population of over 500,000 people. But we absolutely wanted to understand, are the processes we're putting in place from a primary care perspective actually safe? So we actually did an end-to-end analysis of every single case that came into our virtual ward or remote method of monitoring. At that moment in time, we also determined very quickly that we covered a huge age area, as well as trying to determine what are the other underlying conditions currently associated with individual patients. But equally, at that moment in time, we determined it was respiratory conditions, as well as BMI being a key point, as well as ethnicity. But the graphs I want to show at the bottom right-hand side are looking at the detailed analysis we undertook in relation to what were the other parameters around temperatures, pulse rate, and PO2, and quite critically, even then we started questioning what were the thresholds and were they correct. Next slide, please. This is a more detailed analysis of how we did the quality assurance, as well as looking at the parameters. But the most important message here is, as Matt has already alluded to, is understanding actually it wasn't primarily breathing symptoms that patients were presenting with. There was an array of conditions that people may present with, for example, recurrent falls, dizziness, And it's about having a threshold of assessing those individuals. With respect, like all of us, a lot of people were quite scared to go to a hospital. We actually found a number of patients were actually subsequently monitored within the community setting. What were the key interventions? Some of the interventions may have actually been involved in taking on further investigations, asking patients to rest, starting them on courses of antibiotics. Next slide, please. And why is this important? Because actually what we need to remember is that an individual can deteriorate over a period of time. This case scenario demonstrates the importance of CPAP, which I know some of the presentations earlier on in the day have already touched on. And it is about how you can put an early intervention in that can make a difference to a person's outcome. Next slide, please. This case illustrates why something like using a Medipad app was really invaluable. But again, it aligns with the importance of putting clinical safety in at every single point of contact. So it empowers the patient of what to do in the event they happen to deteriorate in the active hours timing, and then an informed intervention can occur. Another key message behind this slide is that even if a swab test is negative, that doesn't exclude COVID as a clinical condition. And the key message here is that it's about clinical acumen, irrespective of age, and determining that there's a method of support that can be put in place. Next slide, please. We've had very positive feedback from the patients who've been monitored, as well as clinicians. And it is a different way of working. Primary care flipped completely in the way methods by which it works. We went almost from about 80% face-to-face to 80% a form of virtual monitoring. Virtual monitoring doesn't necessarily just have to be with respect to an app. It is about picking up the phone and speaking to people. As we all say as clinicians, 80 to 90% of the story is actually in the story is conveyed as part of the history. Next slide, please. So the key question right in the beginning was, can primary care have something to offer? If the right steps are put in place, and Caroline will absolutely go through this in a lot more detail, then I think the answer at this moment in time is a yes. Since then, we've been a part of the national programs, national studies, and more information is coming out. But safety netting is absolutely key. And it is about joining up the whole system. Next slide, please. In relation to how you work, it isn't about individuals working alone. As we've all come from different areas, we're actually speaking the same messaging, I hope. In convening is about trying to keep everyone safe. But equally, it's about working as a collective team and the whole system working together. It isn't just about an individual GP or the ED, it's a collective team. Next slide, please. Next slide, please. Sharing the learning, we've already alluded to that, and thank you to our local confederation. It is working together as a collective team. Next slide, please. And it is really about understanding what do we mean by thresholds. The most important point I want to convey here is that we know a measurement is like taking a photograph of that moment in time. What we're interested in understanding is what's happening over a trend in time. And I think the last message I'll actually leave for you to read from a local patient, which was just conveyed back to us last week, which absolutely exemplifies why we are here. And I know from some of the chat conversations is, can we as patients understand what's going on? The most important thing is give them the diary, give them the information, and make them and empower them with the information that's currently available. I know I've tried to keep the time. I'll hand over to Caroline, but there's a lot more out there, and primary care absolutely has a key role to play. And thank you to NHS England for finally hearing our voice. Thank you.
Over to you, Caroline.
Thank you very much, Cordelia. Sean, can you see my slides?
We can see your slides, yes. I hope everyone else can as well.
Lovely, thank you. So my name's Caroline O'Keefe and I'm a GP in North Hampshire. I just want to tell you a bit of a story, I suppose. In the first wave, we came together as 11 practices covering 5 PCNs and a population of 200,000 to set up a COVID assessment centre. We very deliberately cast the net quite wide for that assessment centre. We saw anybody obviously with COVID-like symptoms, but also anyone who was febrile, anyone who had respiratory symptoms. And over the 15 weeks we were open, we saw just over 1,700 patients and sent just over 100 of them into hospital. Lots of positives we took from that experience. Lots of really strong local collaboration. Some really strong relationships were built actually between primary, community, secondary care. And I think we left with a real can-do attitude about how that works. We certainly identified some lessons and some things we wanted to do differently in the second wave. We staffed it in quite a GP heavy way, and we recognised that actually in the second wave, coming as it has in the middle of winter with a lot more business as usual pressure, that was going to be a challenge. And also infrastructure, it took up a sort of large share of one of the primary care buildings, which again is being sort of far more intensively used now. Now, Matt's talked very eloquently about why we needed to do things differently in the second wave. So I'm not going to repeat any of that, but I do think that we all sat down at the end of wave one and decided that we knew why we needed to do things differently, both clinically, but also organisationally, in order to allow us to carry on with our business as usual. So then we identified what we needed to do differently. And I think what Matt and his team have done so incredibly well is pull together this single clinical pathway so that we're aligned at national level with national parameters. We all know, whether you're a member of the ambulance service or a GP or somebody working in out of hours, at what saturation level somebody needs to go to hospital, at what saturation levels people need to enter the virtual wards, really aligned nationally. And that's been so important. We needed to define, and Matt's graphs did that, the clear patient flow as to how people move through the system. And I think the other thing that was critical with our planning for wave two is how we reflected that in hours and out of hours. This has to be a 7-day-a-week service. There's no way this can be done Monday to Friday. So we decided to use our hot hub model again at scale. We recognized we needed to get patients in early, assess them early, get those baseline saturations measured early, have access to rapid testing, and also provide safe assessment for under 18s. It was really important that we don't miss unwell children because we're focusing on COVID. And aligned with those hot hubs, we were able to set up the COVID oximetry at home pathway and the virtual ward. There's been a lot of collaboration, a lot of support, and a lot of national learning, and I'm hugely grateful to certainly to Matt for guiding that, but to all of the people who've been involved. So this is where we are now. We've called it a winter assessment centre, mainly because we're seeing other viral illness there as well. It is a single hot hub. We're covering a population of 230,000. We've been open 6 days now, and similar to the previous entity, we're now seeing all patients. We've got access to all patients with fever, anosmia or respiratory symptoms. All over 18s are having access to point of care testing, which has been really helpful because it means that we can get an instant answer and make instant decisions about their virtual wards. We're staffing with a mixture of clinicians. We're using GPs, but also physicians associates and allied health professionals, and that's helped to take some of the pressure off GPs. And aligned to that, the Winter Assessment Centre, we've started a COVID oximetry at home pathway, again covering the same practice population, patient population of 230,000. It's co-located at the Winter Assessment Centre, and again, we've been open 6 days. It's 7 days a week. We have our out-of-hours provider able to sort of follow patients up 7 days a week. And actually, it's being staffed by a combination of a lead A&P supported by care coordinators. And I think I wanted to reinforce something that Matt said earlier on. At its very basics, this virtual ward COVID oximetry at home should be simple. Essentially, what we are doing is giving somebody a pulse oximeter pack, and you can see from my slide what's in that pulse oximeter pack. We're going to give people a pack to allow them to monitor themselves at home, and we will be checking in with them every day to make sure they're not getting worse. At its most simple, that is all it is. How we do that, there are lots of clever digital solutions. We have a particular solution using EMIS and Accurix that we're using. We have spreadsheets that we're using, but actually at its most simple, and certainly for anyone out there that is feeling a bit daunted about setting something like this up, it is purely giving somebody a pulse oximeter and checking in with them to make sure they're okay. So as I say, we have an IT solution which we're using, Accurix COVID monitoring Florey, which sends an automated text so that patients can submit their data daily for 14 days. And we're monitoring them, as I say, for those that don't have access to phones or a digital solution, we'll be picking up the phone and we're issuing patients with paper diaries. I just wanted to show you this. This is an extract from our SOP. And as much as anything, it just wanted to give you an idea of the ways in which people can access the COVID oximetry at home pathway. Top left is having been seen on our winter assessment hub, and obviously that's a direct access point because we're co-located, but we're also able to take patients who have possibly been assessed at the hospital or in the emergency department, maybe who've been seen on a home visit, been assessed by our local ambulance service, our local community nursing service, or out of hours. They can enter the pathway through any of those entry points, and then they'll be, as we call it, onboarded into the pathway and then entered into the system. And likewise,
Caroline, I am sorry, Caroline, we're running out of time. If
okay.
I can ask you to...
I'll rattle through. This just gives us an idea of what the nursing team will ask, and those are the questions, and really just checking how patients are doing as they go through and escalating those who aren't doing well. This just gives us an idea of what the patient diary looks like, and there's a wonderful YouTube clip that has been set up really to explain that process for patients. And again, these are what some of the Accurix texts look like that patients see. So finally, I just wanted to show you this because this was originally a slide of Matt's, and I just wanted to show you this. To me is the sort of holy grail of remembering that we need to be monitoring patients through this system, both in and out of hospital, but also in and out of hours. And I think this has to be a 24/7 joined up primary secondary solution. Thank you. I think I'm now going to pass on to our secondary care team. Thanks,
Thank
Tara.
you. So I think we're next going to hear from Tara. Take it away, Tara. And if I could ask you to rattle through as quickly as possible, so I think we're running out of time.
Okay. Next slide, please.
Yeah. Shall I? Well, I think I'm the next slide on there. Yep. Oops. Hi there, Sean. Sorry, it's me. It's Matthew coming through. I'll go through the slides reasonably quickly, just to sort of catch up a little bit on time. So we, both Tara and myself, have been involved in running secondary care services for patients obviously presented to hospital, being discharged from hospital. Slightly different take, slightly different type of patients, often sicker than some of the patients seen or managed within primary care. But the main aims remain the same. It's good, thorough clinical assessment of patients. And I guess the secondary care service, the focus is on either preventing admission or supporting early discharge. Can you go to the next slide, please? And a virtual ward aims to identify deterioration early by monitoring patients' vital signs, oxygen saturations, pulse, blood pressure, temperature, GCS and respiratory rate, and clinical symptoms, and to provide suitable management. And we've got to remember that it's not just about COVID. There'll be patients who've got COVID and bacterial pneumonias. There'll be patients who've got COVID and pulmonary embolisms. There'll be patients who don't even have COVID, but they started off as if they might have had COVID, who get referred in. So it's about a good, thorough clinical assessment and management of all of the patient's problems. Can you go to the next slide, please? And I've put here some key ingredients, but these are all fairly sort of obvious things. You need agreed referral and escalation pathways. They're absolutely crucial. A process of reviewing patients daily, and a means of monitoring the patients. It could be as simple as a piece of paper and a telephone, which is how we started, or with complex as sort of home gadgets that work by Bluetooth and feed continuous sort of observations from the patient at home to a centralized dashboard, but it doesn't need to be that complex. And proper safety netting and out of hours advice. Next slide, please. So you don't need lots of text, but it does save a lot of time, and that was our experience. Go to the next slide, please. So this is the model that we used in West Herts, but based in Watford, St Albans and Hemel Hempstead. And in essence, we had a number of referral pathways into our service. And this is adapted from an article that we popped in the HSJ in early April, I think, quite early in wave one. All the patients were reviewed by a respiratory consultant at the beginning of their journey if they met the entry criteria, and were triaged into low risk or high risk pathways. And patients on high risk pathways had far more telephone calls, which turned into virtual sort of video conference calls later in wave one than the patients in the low risk pathway. Can you go into the next slide, please? We slightly modified our entrance criteria, so we now use the source score in our local pathway, which is something we derived in Watford. I've put the links here, but in essence, like a lot of these scores, this has been validated against the Azaric data set, but is what we use locally as it was derived in our local patient population. Hypoxia is a pretty key thing, as is respiratory rate. The other variables are all fixed. You can't change your age or obesity, or not acutely, and whether or not you've had a stroke or neurological problem, but saturations and respiratory rate are variables. And we took a source score of 1 or 2 as being managed in the virtual hospital, a source score of 4 or above as being a definite admission, and a source score of 3, a bit of clinical judgment. Go to the next slide, please, based on whether or not the source score was high because of age or because of a clinical variable. And we took 3 as the point where there's an inflection point in mortality. So 1, 2, and 3 was not that much difference, but 4 and above there was. Next slide, please. When we got started, we had 2 respiratory consultants and 1 respiratory physiologist, 500 SATS probes that we got from our friendly SATS probe supplier, and a grab pack from A&E, which was a bit like a kid's party bag, which had SATS probes and patient information leaflets, temper dots, because we couldn't get hold of thermometers for love nor money. We had lots of SATS probes but no thermometers, and some SOS information. We started off using a simple pooled Excel database, although we did develop an electronic patient record over time. Over the 14 days we followed patients up, we spent about an hour per patient over those 14 days. By the peak, we had a pretty large team. Next slide, please. We monitored symptoms, saturation at rest, 40 steps and 1 minute sit to stand if it was safe to do so, and heart rate, as well as blood pressure for a certain number of patients. We had some with ambulatory ECGs that were being used as well. Next slide, please. I go slightly quickly. These are our referral numbers to the virtual hospital by day, starting on the 13th of March, and we're starting to get a bit of a peak again. We've got just over 1,800 patients now. Next slide, please, over the 2 waves. And these are some of our outcomes you can read afterwards, but we had low complication rates. All of the deaths occurred actually in wave 1. We've not had any since the first 900. So our mortality rate is now under 1% for the 1,800 patients that we managed. And of note, this is an older, sicker cohort than many of the primary care cohort. 60% have abnormal chest radiographs, 30% were hypoxic at the time of referral. Only 2% suffered from deaths. They were obviously in the older age groups. Next slide, please. So technology made things easier, it made things quicker. We used the Medipad app, as did Calderian team in Northwest London, saved quite a bit of time for us. Next slide, please. And next slide, these are just pictures of what the app looks like. Next slide, please. And this is the Clinician Dashboard, which sort of highlighted to us those patients who were sicker and needed calls versus those patients who could just receive a sort of a WhatsApp style sort of notification on their phone that we'd looked at their observations and everything was in order. Next slide, please. Likewise, the clinician could see trended data, which I found particularly very useful, and that old clinical adage that the trend is your friend, I think is crucial, and being able to look, I'm very visual, so being able to look at plotted trended data of oxygen saturations, and next slide, please, and symptoms such as this was very useful. Next slide, please. And this is our current pathway, really going into whether patients use an app or not. About half the patients recruited used an app in the latter part of wave 1. So we provide service for both patients who use apps versus those that don't. And I think that's crucial for any service, that you are available to all people regardless of their technological sort of savviness. Next slide, please. All of our patients get followed up in a post-COVID follow-up clinic. And I'm going to hand over to Tara now. Next slide, please. Okay, next slide. Tara, are you able to come in?
Yeah, so just very briefly then, because I know we're running out of time. I'm an emergency physician at Royal Free in North London, and I just wanted to talk briefly about our slightly contrasting pathway to MATS, which is a very low-tech pathway using an ambulatory telephone clinic. This is our ED pathway. Patients were selected based on their news tube parameters, their D-dimer and their CRP, using parameters set by early Chinese papers, which we've now revised based on our own data, to select which patients we could ambulate into our ambulatory telephone clinic. Next slide, please. Patients were called every day using an ED registrar or an ED consultant. They went home with a pulse oximeter. So using the SOP, we asked standardised questions, which again has been revised using QI methodology to make sure that we're developing as we develop our learning in what we're asking patients. Next slide, please. Patients again were sent home with patient information leaflets and a diary and given written and verbal advice and safety netted every day on the daily telephone call. Next slide, please. Our outcomes, we ambulated 84 patients, 25% of those required subsequent readmission. This was during the first wave when we were pretty much nearly overwhelmed. And so we have lowered our parameters for ambulation since the first wave. But I'm pleased to say that we've got a less than 1% mortality rate. during the first wave, we did ambulate people that really didn't want to come into hospital with significant comorbidities. So we had quite a wide range of patients who we did put on the pathway based on patient request. Next slide, please. I'll skip over the headlines. So if we could just skip past that one to the next one. Obviously, again, like most of the others on this call, patient feedback questionnaire was excellent in terms of patients really preferred to be managed at home rather than being managed in hospital, and they felt safe at home being called every day. And this was at a time when we didn't know very much about COVID. And even though there was a lot of scary news and around, patients still preferred to be managed at home and felt that that was an appropriate place for them to be. Next slide, please. So really just summing up then, I think from what everybody said this morning, it's become apparent that virtual wards are rapidly becoming a key element of how we deliver same-day emergency care in this country. And many sites, next slide please, are managing to split their same-day emergency care services into respiratory and non-respiratory, using a virtual ward to support their COVID positive patients. And as we get rapid testing online at the front door, it's going to be even easier to select which patients are most appropriate to put into the virtual ward and to manage alongside other respiratory patients to prevent cross-infection. And as Matt said, it's really important. COVID isn't the only diagnosis, so we do need to make sure that we get the diagnosis right early on in the patient journey. So that will really help us. Next slide, please. So virtual wards in the future as we move forward will support SDEC delivery in this country, and all of the work done by all the people that have presented prior to me just shows the absolute groundswell of enthusiasm and innovation that's been going on over the last few months, delivering hospital-based services without requirement for admission, or with ongoing monitoring for deterioration, innovative technology being used to monitor patients in their own homes, and really critically, locally designed services by people that are delivering these services locally. And Matt Knight and I were talking about this before this presentation. I think he's coined a really great phrase. It's basically a glove that fits any hand, and people have been doing it in droves up and down the country, developing their own services using what they have available to them locally. And so finally, last slide, as we move forward in an era of rapid evolution in acute healthcare in this country, the hope is that the lessons learned during this pandemic, with all the collaboration, learning and innovation that's gone on over the last few months, will help us to utilise virtual wards to manage patients with acute healthcare needs closer to home or even at home in the future. Thanks very much.
Excellent. Thank you, Tara. I'm afraid, everybody, that we're well over our time and crashed into our next session, but that's my fault, nobody else's. We'll try and facilitate some of the questions in the chat session. I think today's presentation has been fantastic in telling us some of the opportunities that there are out there in improving care for people in the community, which, let's be honest, everybody wants to be in their own home, don't they, ideally? And this is really important work that's going on, and we'll look for the guidance that Matt mentioned that's coming out in the next few days, but I'm afraid we don't have time for Q&A. So I'd like to thank all the panelists for giving us their time today. Thank you very much. And for those of you attending our next session, which starts in a few minutes' time, you can find the link in the platform for the virtual Congress. But thank you very much, everybody, and appreciate your time this morning.
Okay, so it's just back to us. So it's a lot in 5 minutes, isn't it?
Oh dear.
It's quite hard to get the